Center for Tourette Syndrome and Associated Disorders. Its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Welcome. Before I begin the introduction of tonight's presenter, I'd like to call your attention to the slide on your screen about our annual family retreat, Camp Bernie 2014. This is our 10th anniversary camp, and registration will be closing on May 1st. Space is limited. If you're interested in attending, don't delay. You can go to our website for details and registration. Camp Bernie has been described by one of our families as one of the best weekends of the year. For families living with Tourette, it's a great opportunity for kids to make friends and for parents to connect with other families. Now to the introduction of tonight's presenter, Dr. Lawrence Brown. This is Dr. Brown's third appearance in our webinar series. His previous topics were After the Diagnosis and Beyond Tics, done in April 2008, Sleep and Developmental Disabilities, presented in March of 2012. Those webinars, as well as tonight's, are available for free download on our website. Dr. Brown is an Associate Professor of Neurology and Pediatrics at the University of Pennsylvania School of Medicine and Children's Hospital of Philadelphia. He is Director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children whose complex learning and behavioral issues have a neurobiological basis. This population includes children with Tourette syndrome, high-functioning autism, complex ADHD, epilepsy, genetic syndromes, and other neurological disorders. Dr. Brown is a senior clinician in the Pediatric Regional Epilepsy Program at Children's Hospital, where he is principal investigator on numerous clinical drug trials in pediatric epilepsy. In addition to his wide interests in behavior and epilepsy, he is board certified in sleep medicine and has numerous professional affiliations in the child neurology and epilepsy fields. Dr. Brown, welcome, and thank you for joining us tonight. And without further introduction, I'll now turn tonight's presentation over to you.
Hi, Marty. Thank you very much for that lovely introduction. I hope everybody can see my screen, and I'll be speaking for the next 30 or 35 minutes, and hopefully there'll be plenty of time for questions. What I wanted to do tonight is to talk about Tourette syndrome and how it relates to some of the more common developmental disabilities. But first, I have to figure out how to turn the slides. But first I wanted to talk about Tourette syndrome itself before adding the complications about developmental disabilities. We all know that Tourette syndrome didn't just turn up at the end of the 19th century when it was first described by Georges-Gilles de la Tourette, who at the time was a medical student describing individuals with movement disorder. In fact, the first time that I could find it described was in a book about the Inquisition, where it was described as a devil's project. It was only maybe 50 years ago that serendipity came along and treatment for major psychiatric disorders was instituted because, as the Chinese say, if all you have is a hammer, everything looks like a nail. And treatment was used with some of the major antipsychotic drugs, and lo and behold, it improved the tic disorder, leading people to realize that this may well be a brain disorder and not the underlying emotional disorder that it was believed in the past. Over the last few decades, a remarkable amount of research has proven that tic disorders are a neuropsychiatric problem that does not come from one single gene, and it does not come from one single source, but it's rather extremely heterogeneous and has been the reason why we're no further along in a full understanding, because it is so complicated, and I'll come back to that later. You should be aware that very recently the diagnostic criteria, as put forth in the Diagnostic and Statistic Manual of the Psychiatrists, have just made some minor changes in the medical scientific definition of Tourette syndrome. Nothing major, nothing that changes anything significant, but you should be aware that it is always defined by the tics, nothing else, multiple motor tics, at least one vocal mannerism at some point, and that this has to be present for more than 1 year. The gray area shows the change with DSM-5. It used to be said that there had to be no tic-free period for more than 3 months. That's no longer there. The onset is still a pediatric disorder. The closer one is to adulthood, before showing tics, the more one has to consider another way to get those tics from a medical or genetic disorder different than what we call Tourette syndrome. And what else has changed is that in the past one could only call it Tourette syndrome if it caused problems and impaired function, whether it be in school, in the social arena, or at work. And now, because that's so hard to pin down, that's no longer part of the definition, and that may change how frequently we can call people with Tourette syndrome. Still there is the fact that it can't be caused by a direct effect from substance abuse, by the use of stimulants, or some other medical condition, which gives us a differential diagnosis. And we do see children where we have to admit them to our epilepsy unit because they have mannerisms, and they could be seizures, epileptic seizures, almost never, but we have to consider it. And there are other conditions. So as we go through this, I'll be offering some take-home messages. And the first is that Tourette syndrome is defined by chronic tics, but notice that there's no mention of any coexisting problems. There have been a number of epidemiologic studies in the past, and several of them can help to define how frequently we should be thinking about it. If one looks in the area around Rochester, New York, in regular classrooms, 0.8% of children fit the definition of Tourette syndrome, but when they went and they spent 3 or 4 visits in the course of a school year, there was at least one tic on one occasion in almost 20% of children. If one looked at special ed, where children had learning or attention or other physical or neurologic disabilities, the prevalence was twice as high. and in checking out ticks, almost 1 out of 4 children had it. This has been replicated in other areas. In eastern Connecticut by Yale, definite Tourette syndrome with disability was seen in 3 out of 1,000 children. And again, almost 1 out of 4 had at least some tic on some occasion. Does this persist throughout childhood? The only study I could find was coming from the state of Israel, where all 18-year-olds have to be examined on their way into the Army, and 1 out of every 2,000, or 0.02%, of boys had it, and it's about half that in girls. So the best estimate for the prevalence of Tourette syndrome is somewhere between 1 in 100 and 1 in 1,000. So what can we say about how frequently it's out there? I just said that it's between 1 in 100 and 1 in 1,000. The lower estimate includes about 600,000 children in America with impairment, and the upper bound includes all chronic recurrent motor and verbal tics. They're much more common in boys, and overall one must consider this as part of the normal spectrum of development because it occurs in at least 1 out of every 4 children. Why does it occur? Everything that we know points to this part of the brain called basal ganglia. That is the central way station for movements, and remember, the vocal sounds are really movements of the vocal cords, and this is a very complicated wheels within wheels of both positive and negative reinforcements, so that when I think about moving my arm, I move it exactly where I want it to go, rather than a jerky movement or a repetitive movement. But those fine-tuning does not always occur during the rapid development that's going, and with the connections from the part of the brain that we're talking about. So what the science has shown in the last decade is that normally the basal ganglia does provide the way for the motor pattern to proceed with selective facilitation and inhibiting interference by other competing motor habits by inhibition around the area of excitation. But in Tourette syndrome, it appears that there is increased excitability within parts of the basal ganglia, but normal inhibition, and this leads to exaggerated or repetitive or widespread motor activity involving other body parts than the one that was originally intended to move. Put it all together, and it appears that when the circuits mature, that may help to explain why it's so common that Tourette syndrome symptomatology improves spontaneously as most children approach puberty and adolescence. It also explains some of the more interesting phenomena that one sees, both simple tics, which are just movements or sounds, and more complex tics, which are more purposeful looking, and they can be controlled in different parts of the neuraxis within the basal ganglia. It also, as I would like you to understand, because of the connections to other parts of the brain, such as the frontal lobes that are so important for focus and for decision making, what we call executive function, can be affected. And in the orbital frontal regions, deep in the front part of the brain, is where OCD or compulsions can be derived. And so when one thinks about tics and say, well, why should we have all these other problems associated? It's because, as the old saying goes, the hip bone's connected to the knee bone, that this part of the nervous system that's so important is not in isolation, it connects, and we can see other associated issues. Now, this is an old slide that I want to go through. It's a little complicated, but if you start at the bottom, you can see on the x-axis is the lifespan of a child, and you can see that even back 30 years ago, we recognized that what was then called hyperactivity, what's now called ADHD,
Dr. Brown,
first thing that was seen.
Thank you.
Yes, ma'am.
I was just going to tell you your slide had not changed, but thank you.
The ADHD is the first thing that's typically seen in children who are destined to have tics, if that does occur. And when the tics come in, they typically come in the early elementary age, and it works their way down so that eyes, face, neck are much more common than arm, and then only later the trunk. And the same thing is true with complex tics, that the simple ones come first. The phonic tics tend to come a little bit later. And you can see back 30 years ago, echolalia and coprolalia, or cursing, was very common. And notice lastly that compulsive behaviors, what we now recognize as OCD and related disorders, come in even later. So that there is an ontogeny. It starts with ADHD and then tics, and more complex tics and OCD. Over the last 30 years, we've certainly seen an explosion in the recognition of ADHD, but we've also seen some other things that have changed. And one of the most interesting is that we now recognize what are called premonitory urges. And so any of us can see somebody who scratches themselves, but most people scratch because they itch, and that's really hard to see. Older children and adults often will tell you that they have to tic, and that by doing the tics, they can feel better. And this is so important because it's given the impetus to habit reversal and cognitive behavior therapy by allowing people to recognize the control that they can have, and we'll come back to that. Over the last few decades, we've also had improved medication, better understanding of the pathophysiology, and in my practice, virtually nobody has coprolalia. Street talk, yes, but the constant cursing or the related copropraxia, the giving the finger and not meaning anything by it, is really a very rare phenomenon, less than 5%. The way I like to think about Tourette syndrome these days is that we start with a genetic predisposition, and then what's called epigenetic factors, or something in the environment that triggers a change that allows it to appear, and that starts a cascade. And we think that it has to do with irregularities within the basal ganglia, leading to hyperinnervation of dopamine neurons and increased dopamine transmission in this area and its connections, and that's how you get tics and ADHD and OCD. One of the things I'm not going to talk about tonight is the differential diagnosis, because there are, on very rare occasions, other things that can look like tics and look like movement disorders, but are coming from a different problem. Sydenham's chorea, or St. Vitus stance, is a streptococcal-related disorder that we've known about for 150 years, and we have other forms of movement disorders that can be caused by everything from genetic issues that affect the liver or that affect the brain. We call it Wilson's disease, Huntington's disease. Autism, and we'll talk about that momentarily, can be a totally different disorder, or it can coexist. I've already mentioned when people have a tic-like movement and altered awareness, that it can be mimicking a form of epilepsy. And of course, everybody wants to know about pediatric autoimmune neuropsychiatric disorders associated with strep, a very rare condition indeed, which has gained popular interest, but it is extremely unusual. My message is, in my practice, when I see a new patient, there is usually a very minimal workup not addressing these conditions unless there are reasons to look, especially if the child is otherwise neurologically and developmentally normal, and especially if there's a positive family history of tics and/or OCD. So let's talk briefly about how to treat the core symptoms, that is the movements and the sounds. And why would you want to treat it if I told you that I don't believe that for most people it's a disease or a disorder, but it can cause functional impairment. It can lead to problems in making it through the day. We have kids who have severe headache because of their neck tics. We have others who are having learning issues because their eye movements keep them from focusing. And we have yet other children who work so hard not to show their tics that they can't focus, much like the driver who says that he can do everything even though he's on his cell phone while driving. We know he's a better driver. We know the children can learn better if they were not also trying to do other things. In my experience, what's more disruptive in school are the vocal mannerisms that affect other people's concentrations rather than the movements themselves, and the very complex ritualistic tics that can take time and disrupt others. And altogether, this can lead to psychosocial impairment. So when there are disabling symptoms, I think one can address them and should address them, but you don't have to and you shouldn't address all things simultaneously, but rather work on the most difficult one, whether it's the tic or whether there's some other behavioral aspect that's causing the majority of the problem. Pushing a child in the direction of better control, better concentration, can calm things down and improve tics as well if one first addresses the ADHD, for example. There are other ways to treat. The very first thing that I talk about is educating the family to support the behaviors that I consider within the broad range of normal variability. Teaching a child to relax, having supportive individual or family counseling can help, and as everyone should know, cognitive behavior therapy, particularly with habit reversal, has been endorsed by the Tourette Syndrome Association and can be very effective and has been shown to be effective in up to 80% of individuals. And what's most remarkable to me is that even those children who may not be objectively remarkably improved often feel much better and are in better control of the situation with cognitive therapy. The question for me is how young can you do this? And we are pushing the limits further down. I think that it's clear that most adolescents and pre-adolescents would benefit, but not every child under the age of 10 is ready, and in fact there are some older children who are not ready to work with an experienced and effective counselor if one can find him or her. I've been reproached by the psychologists that I work most closely with when I've said that cognitive therapy is almost always the very first treatment, because I've been told that for at least some children who have severe problems, it's too much for the cognitive therapist to get started with until medication can help to reduce the burden of tics and anxiety and OCD, that it can be much more effective when there's a partial response to medication at the very least. We do see that medications are effective, and most medications that I start with are guanfacine or clonidine, the adrenergic drugs. They are not effective in 100%. They're only effective in 50% or more, but they have other benefits. They can improve sleep. They can improve ADHD. They can improve aggression and even anxiety. One needs to be careful because too much can make you sedated or irritable. I prefer these days to use the proprietary Intuna preparation if a child can swallow a pill, not because it's that much stronger by any means, but because it prevents the peak effect of guanfacine, which can be sedating or irritable making. And one can use it once a day, so it's much less intrusive than the 2 or 3 times a day. Only when there is a sleep problem, I go to clonidine, which used to be the only thing available, but in fact this requires multiple dosing unless a child can use the new proprietary cafe version. I rarely these days use the patch, which is available, but it's a first-generation patch and often produces skin irritation in about 1 out of 5 children, so that doesn't help for very long. We do use, on occasion, the atypical neuroleptics, and there's a typo there. It should be atypical neuroleptics, Risperdal, Abilify, and Geodon. Each of them have benefits. Risperdal by far is the most widely used with the most experience. We thought Abilify had much less sedation and much less weight gain, but that's not true. And the one with the least weight gain is Geodon, but it has the most sedation. So one needs to be very careful about using highly effective drugs, but with much higher risk of side effects, both short-term and long-term. We have other treatments as well. Some with better experience in science, others like Keppra or levetiracetam with very minimal experience. And the only two drugs that are FDA approved are Haldol or haloperidol and Orap or Pimozide, both of which for most children have severe side effects and a much higher risk of both immediate movement problems and long-term tardive dyskinesia. Medication can certainly help with the target symptoms, but and it can also reduce reactivity and aggression, which of course in teenagers and even younger children could be the most disabling. But medication can't teach good behavior, can't teach how to make good choices, can't achieve learning or teach a child how to deal with feelings, make them motivated, and none of it can cause a cure for the Tourette syndrome or the other conditions. And the one thing that I do want people to recognize, because with every medication one takes a risk-benefit, and that is that medications can't cause Tourette syndrome. Stimulants can increase tics in about 20%, but they can also be the most effective in helping with the symptoms of ADHD, if that's what the major problem is. As I've already said, ADHD comes earlier than tics, and therefore when one has new tics after treatment with ADHD, more likely it's the unraveling of a genetic predisposition. As a neurologist, I want people to realize that some medications have been rarely reported to bring out tics. For those seizure medicines that are also used by psychiatrists for mood stabilization. But again, if things don't happen within the first few weeks, it's very, very unlikely to be a medication effect. And equally important, if it is caused by the drugs, when the drugs are stopped, the tics will go away. Finally, let's talk about what is a developmental disability. The CDC says it's a group of conditions due to physical learning, language, or behavior that can be detected early in life and often persist throughout the lifespan. And here are a list of among those things that the CDC says can be considered a developmental disability, some of which, like cerebral palsy, are clearly always a developmental disability. Blindness, hearing loss, intellectual disability, what used to be mental retardation, but they also include Tourette syndrome as a condition, which makes it a little bit complicated because we're talking about developmental disabilities along with Tourette syndrome. If one looks at all of the conditions that have been considered to be those pediatric disorders that are lifelong and can affect the child's function, 1 out of every 6 children could have something that fulfills that criteria. I think most of us recognize that at least 2/3 of children who fulfill criteria for Tourette's also have ADHD symptoms, and OCD, whether it be just the obsessive or ritualistic behaviors that do not fulfill all criteria, or OCD itself in about 20 to 30%. Autism is more frequent. Intellectual disabilities and learning disabilities can also be prominent, as are mood disorders and anxiety disorders. Why do we talk about it? Again, as I said from the very first slide, tics define Tourette syndrome, but these other things can often be more disabling and even long-lasting. A recent survey of thousands of patients in the Tourette Consortium suggested that 7 out of 8 had something else along with tics. And in my practice, I often see tics being outgrown, but other symptoms often continue into late adolescence and adulthood. Here's 2 of my favorite slides. The inattentive type, if you can't read it, it says, "Excuse me, doc, my attention wandered. What type of disorder did you say I had?" And the other, the classic Dennis the Menace, by the time I think about what I'm going to do, I already did it, the hyperactive or impulsive type. What we see in clinical practice is typically both the combined type that comes to attention in early elementary school grade. Why is that so important with Tourette syndrome? As I said several times now, the ADHD typically precedes the tics by years, that it is so common in 60 to 75% of kids with Tourette syndrome, that the stimulants, while they don't cause Tourette syndrome, they can make the tics worse in those predisposed children. And it's easy to look at the medication and say that the tics got worse, he's on the medication, therefore the medication made the tics worse. But one has to be very cautious. But the most important reason is that if a child fulfills criteria for ADHD, with or without tics, it's the ADHD that predicts ongoing school challenges, even when you account for coexisting learning problems or the severity of the tics. So that ADHD itself can make the situation much more serious. How should you then treat Tourette syndrome when there's also ADHD? Certainly, you never start with medication. You start with the behavioral and educational strategies. Stimulants are really important, and I use them all the time if the parents are willing to accept the possibility of increasing transiently the tics. But almost always we'll start with the less effective medications that take longer to kick in, because people want the balance between efficacy and safety. There are other treatments. They're usually slightly less effective. Atomoxetine is known as Tourette. There are older antidepressants that don't produce tics but can help, and only would I use powerful medications and stimulants as a last resort. My suggestion is that if ADHD is the most severe, strongly consider one of the long-acting stimulants. We've already discussed guanfacine and in the interest of time, I'll move on. But one does need to remember that it's not an overnight solution. Even when it does work, it often takes 4 to 6 weeks. And the other practical thing I would say is for the older children, the highest available dose may not be quite enough, and one may need to push the envelope a little bit further. I should say that Tourette has improvement without worsening tics for ADHD and should be considered, but again, it is a long-term play. There are potential side effects with it, particularly GI, and one needs to, again, give it at least 4 to 6 weeks. OCD is something that we mentioned, and I think it's important because OCD, kind of like tics themselves, overlap between normal behavior. Certainly repetitive play, night rituals, being totally involved to the point of having to, these days, have a frozen dress and a frozen blanket, or unusual collections, can all be developmentally appropriate. And some children are very shy, or anxious, or resistant to change, and we don't want to give everybody more diagnoses that don't make any difference. So we want to be very careful. On the other hand, OCD, when it occurs, can really be disabling. It can take time, it can cause distress, it can interfere. And it's hard in children because they don't always show things in the same way. They may just appear to be withdrawn or anxious or unwilling to participate or be unable to go with the flow at home or at school. By definition, older individuals should be able to say that the reason they do things is because they have to. They know it's not necessary. They know it's not for real. They're alien thoughts, but you can't always ask that to a young children. So you may need to infer what they're thinking about. One thing that has come out in recent years is the difference between OCD with tics and OCD when tics are not part of the picture. When it's with Tourette syndrome, most older individuals will be able to tell you that they do things because it has to feel right. When there's no tics, individuals will tell you that they do things because if they don't do it, something bad will happen or to cause something good to happen. And so there is a difference in mental symptoms. It's important that we recognize the difference and treat it when it interferes. How does one treat it? For this is quite straightforward that cognitive therapy is as good as medication, and that medication and cognitive therapy can work very well together synergistically and cause the need for less medication, medication being almost as effective. There are various treatments that are available. One does, again, need to give weeks for things to improve. Mood and anxiety disorders can occur in up to 1 out of every 4 children. And in kids, it's often unclear whether or not it's a primary disorder or they're just responding to the challenges of having a disabling tic disorder. And it's complicated because anxiety can bring out the tics, and if you treat the anxiety, you can help the tics. And so we don't always know whether or not we should treat the first or the second, but again, you try to aim for the most disabling. I added this because I think it's really important that all the medicines that we're talking about that get into the nervous system have been said by the FDA to have a warning about suicidal thinking and depression. And this goes true for antidepressants, it goes through for the anti-epileptic drugs, and it goes through for the drugs that we use for OCD. And what appears to be true is that there is less risk of harming oneself or thinking about harming oneself or thinking about self-injurious behavior when it's obsessive-compulsive or tic disorder than it is for depression. It's important to also recognize that there really is no evidence that anybody has increased the rate of suicidal efforts, but only the thinking. And the FDA has taken the posture where there's smoke, there's fire, and therefore we need to protect the American consumer. And in this case, it's children because it's not true for adults. My take on all this is that one has to balance risk versus benefit all the time. If the problem is so severe and it can work most of the time and these thoughts are very infrequent and can be monitored, then one should not withhold effective treatment. Autism is a really important area. I can only find a slide when it was 1 in 110, then it's 1 in 88, now it's 1 in 61. It's going up all the time. How does Tourette syndrome and autism overlap? Well, almost always when I see kids, young kids who have tics, the parents are asking whether or not this is a symptom of an autistic spectrum disorder. Sometimes it's hard to tell tics from autistic stereotypies. Tics, as you know, tend to wax and wane. They tend to morph and evolve. They're usually suppressible, while stereotypies tend to always be the same and are non-suppressible. What is also true that makes it complicated is that tics are more common in autism. And I think it's because that part of the brain that's affected in tic disorders can also be affected in autism. But that doesn't mean that most kids with autism have tics, and it certainly doesn't mean that most kids with tics have autism. So one study, there's one person who's been studying this for many years, and he did a very nice population-based study in North Dakota showing that 20% of kids with autism met criteria for Tourette syndrome, and he actually made it sound like if you had tics and you fulfilled criteria for Tourette syndrome, you were probably on the better end of the spectrum. I think this was done before we recognized high-functioning autism, and also the other problem was that the North Dakota has 4 children. No, that's not quite true. But the population size was very small. Dr. Bird repeated the study using the International Tourette database, and he showed that almost 5% of kids with Tourette also met criteria for autism. And this database was trying to look at genetics, and they thought that maybe there would be a difference, and there was a slight statistical difference, but one could not use the family history to help in any way, and there were problems with this self-diagnosis of autism. When you have kids, and I never know what to call it because now we should not be using mental retardation, we should say intellectual disability, but children who have significant cognitive delays and are what we used to call mentally retarded often have behaviors that are repetitive, that are unusual, compulsive, and it can be called something that looks very much like Tourette, and this was first noted by colleagues of mine many years ago, and the term was, well, if it's not Tourette syndrome, maybe Touretteism, and the fact is we can treat it the same, but it does not imply anything about the basis of Tourette syndrome except in children who have specific brain disorders. Let's get back in the last moments what the strategies ought to be effective in dealing with Tourette's. I think that you always need to develop a real team, and in these days of fragmented care, at least a virtual team where your educators and your therapists and your physicians and your mental health professionals can all work together to at least communicate by email or phone, to design a program to help each individual to achieve his or her best potential. When possible, and this is something that I've been trying to do more and more, one needs to involve the child in the plan, and the child needs to take ownership, certainly by adolescence, but as soon as possible so that they understand why they're taking medicine, why they're getting special services, and how people are trying to help them. And I think that when one deals with Tourette syndrome, it should always be optimistic, because we know now that the tics have severity that peaks at about 10 or 11 years of age, just at the time when the basal ganglia are completing their total maturation. And so my final take-home messages are that tics typically begin in early childhood, improve by adolescence, that the peak age is about 10, but this may not reflect any one child's story, and that a third become completely resolved of their tics and other conditions, a third are much better, and even in the last third who continue to have some degree symptoms, there is often improvement in most of the symptomatology. It's usually the ADHD, the OCD, the mood, and the anxieties that persist even when the tics get better. We should always be optimistic. I want to end with a plug for the genetic studies that are using the most advanced techniques in order to figure out this complicated and multifactorial condition. The New Jersey Tourette Syndrome Center and CHOP are participating in an international study looking where there's both biologic parents and one affected child, and especially with it, there are at least 3 individuals with tics and or OCD. These are very much of interest, and I hope that you all volunteer. And with that, I know that I went over, and I hope we still have a little bit of time for questions and comments. Thank you very much.
Dr. Brown, thank you. And yes, we do have a bunch of questions lined up here, so I'm going to start right away. I have a question about brain scans. Do you recommend a brain scan to help understand what's going on in a TS person's brain? Can it help with determining proper treatment approaches and so forth? Okay, did you hear me? Dr. Brown, did I lose you?
No, I'm here.
Okay.
I started to answer it before you unmuted me.
Okay, I'm sorry.
If there were a research project that had a specific question, I think it should be done. But in fact, it's only on a research basis that there are differences that can be seen in the size of the basal ganglia. There are differences that could be seen in some of the chemicals that can be studied. But they're very, very subtle, and there's a tremendous overlap between normal and affected. And one cannot use any MRI or EEG or other technique like that would make a specific difference. I do not recommend it for straightforward Tourette syndrome.
Huh. Okay. For another question, for CBT to work, don't children need to want to improve the tics or behavior? This parent says that they've been told their son is not a candidate because even though he's 15, he has the impulse control of about a 5-year-old. Could you comment on that?
Yes, I think that is correct, that one needs to have a certain degree of insight, and one needs to want to help oneself. Of course, you can be taught how to recognize some subtleties, such as the premonition, but if one denies that one's having a problem or has no willingness to try, then it's not worth the weekly energy and effort. One needs to convince the child to first take ownership.
Well, that's always easier said than done, and in my experience, the older they get, the more complicated that gets.
No, I would disagree that when children are treated as mature as they're capable of, they are interested in helping themselves. Yes, it becomes complicated. Yes, kids are constantly pushing their limits and trying to deny that they have a problem, but that's where places like the support groups and especially Camp Bernie can help young children to recognize that this is something that they can deal with and they don't need to hide or be ashamed of.
Oh, thank you for that nice little plug on Camp Bernie. All right, best way to address Tourette OCD. Would that be through CBT or habit reversal?
Well, habit reversal is one of the techniques that is called cognitive behavior therapy. There are other kinds of cognitive therapy that are particularly good for anxiety disorders or mood disorders, that is depression. But habit reversal is the standard technique for treatment of the tic disorders and OCD.
Okay. Are you aware of individuals with ADHD who presented or who have presented with vocal and motor tics in adolescence? Could you talk about that a little?
There are outliers all the time. I've had 4-year-old girls who present with coprolalia, and I've seen teenagers who have long had ADHD who suddenly are presenting with tics following some environmental hazard like infection. So that's possible, but it's not the common presentation.
Okay. Do you think that meds have a detrimental effect to a child's IQ over the long run? In this example, the mom is saying that her son has been on meds since he was 7, is now 21, and he definitely does not seem to be as sharp, that's in quotes, as he was when he was younger. So the mom is interested in your comments, thoughts on that topic.
There's no evidence for any of the drugs that have been around long enough that they cause neurological deterioration or degeneration. It is definitely true that during all of childhood one builds upon previous experiences, and we don't always have kids getting the most they can out of the childhood that they're having. By that I mean that if they're not in the right class, if they're not getting the right support, if they're over-medicated so they're not learning, they may not achieve their full potential. But I think it's way too complicated, and there is neither experimental evidence nor clinical experience that would suggest any reason why one should impugn the effective medications that have been used if they've been used appropriately and effectively.
Okay, so there's no studies that have been done and no evidence for that at this time then, basically.
Correct.
Okay. Can you address social immaturity, and also if there are often physical pubertal developmental delays occurring? I think I'm pronouncing that correctly.
To the best of my knowledge, there's never been any suggestion that individuals who only have tic disorders have any physical, neurological, social immaturity. That is not true with ADHD. One of the secrets about ADHD is that it has been shown, but it has never been quite publicized, that children have neurological developmental immaturity generally 1 to 2 years behind age-matched peers. And so I think what we're seeing is because many of the kids with tic disorders also have ADHD, that it is really what is producing that aspect that is related to the psychosocial and other immaturity aspects that show up as acting younger than their age.
Okay. I have an interesting question, and you have to tell me whether this is something you can comment on or not. But this mom is saying that, or asking, if I was on Prozac and a little anxiety medication during my entire pregnancy, is there any evidence that this could have caused TS in my daughter?
The answer is no. But what is true is that it appears as though when Tourette syndrome runs in families, it is more common to see tics in the males and OCD in the females. We don't fully understand it. We don't really have a good explanation as to why it should happen, but I think that it is the tendency toward the OCD or rituals or anxiety that led to the use of the Prozac, not the Prozac that led to the consequence in the child.
Okay. I think we have time for one more question, so we're going to wrap it up with this last one. How do I know if my 15-and-a-half-year-old daughter is suffering from OCD? She was diagnosed with TS in the 2nd grade, but rarely has any tics now.
Very good question. There are, like with all of the neuropsychiatric disorders, no blood test, no scan test, no other simple screening procedure except for the behaviors. By definition, there are all sorts of kinds of rituals and anxieties that take time, interfere, cause distress, and when it is sufficient in terms of the type of impact on one's life, one either has obsessive-compulsive tendencies or obsessive-compulsive behaviors or obsessive-compulsive disorder, and that is just to a degree. When I say that like with Tourette syndrome and tics themselves, that doesn't automatically mean that one needs treatment or a label, but if it's sufficient, then one needs to recognize what the issues are and the fact that help, whether it be medical or psychological, not only is out there, but can help to feel better and to make it through the day and do so much more that all that one is capable of. And so what I'd like to end with the fact that if there are symptoms, there are people who can evaluate it and to help to decide whether or not you need to have interventions put in place. At the very least, you deserve to understand whether or not it's a problem for you.
Okay, and you know what, Dr. Brown, if you'll hang with us just for one more question. This question was asked in one of the pre-questions prior to the webinar, and we're just kind of getting to that now. It's from a teacher, I believe, or a school nurse, who has a student who the teacher thinks has tics, but the parent doesn't really want to draw attention to it by bringing the child to the doctor. And so the question is, what's the teacher or the nurse's role in this? How strongly should they encourage the parents to go? How critical is the diagnosis part of this for the student's success in school?
I wish I had a better answer. My first impression is how proud I am that the teacher or the nurse is being an advocate for their student. I think that's wonderful. I think that they deserve credit. I think that many people would reverse the situation and say that the teachers don't always seem to understand the child. Here, it's that the parent doesn't seem to recognize that there may be a problem. The fact that it is present in school, of course, suggests that there's something wrong, because it tends to be more severe at home than at school. What can the teacher do? Because it's not a life and death situation, unless it really is adversely impacting the child's function in the class, they're on thin ice. But to help the parent to be accepting and to recognize that it's nothing to be embarrassed about and nothing to hide from. It doesn't mean that they need to have something done, but they do need to recognize that this can affect their child, and they need to know where it's coming from and what their options are. The best that they can do is to say something to that effect in a positive and non-discriminatory way. And after that, if the parents don't accept it, I just don't know if there's any hope.
That's interesting, because it doesn't say here how old this child is, but the things that we see here in the office and talk about a lot are the socialization parts of this. Like, this kid, I have to say, must know they're doing something. So it's got to be really hard for them to to not understand what's going on with them. And as it turns out, that it is a school nurse, and she said it's a 13-year-old boy. So to my way of thinking, this boy recognizes that he's doing something that's different, and in the interests of, if he doesn't understand it, then he makes stuff up in his own head about what he's doing. Am I off on that?
No, you're absolutely right. And in my experience, the one thing that I feel like I have missed the boat on is proving something which I'm convinced is true, and that is that the severity of the tics are not the best indicator of how well a child will do ultimately, but how well the tics are integrated in and accepted in their life. I've seen kids with very mild tics who are disabled, and parents are despairing, and I've seen other kids who are totally resilient, and the severity of their tics have never stopped them for a minute. And those are the kids who I think understand, those are the families who accept, and those are the environments in school and on the ball field and wherever that support the child and say, you are Johnny who has some tics, you're not the kid with tics whose name is Johnny. And that's what I want for everybody.
Well, I think that's a great note to end on. So thank you for staying with us a little bit longer, Dr. Brown, as well as everybody else. Appreciate that. And I am going to sign off, and Kelly's got a couple little things she needs to wrap up with. Thank you.
Thank you for joining us on our webinar, TS and Developmental Disorders. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that we didn't cover in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website shortly. Our next presentation, Treating Very Young Children with Obsessive Compulsive Disorder, will be presented by Dr. Joelle McGovern and is scheduled for May 21st, 2014. This ends tonight's webinar. Thank you, Dr. Brown, for your presentation, and thank you everyone for attending. Good night.
Good night.